Good morning, everyone, and welcome to our second panel on the topic of the importance of equity. My name is Ann Murphy, and I'm the Department Administrator for Learning Health Sciences here at the University of Michigan. In addition, I've spent much of the past 10 years of my career working within the National Organ Procurement Transplant Network with a community that focuses largely, to a great extent of their effort, on the issue of equity in allocation of a scarce resource in organs across the nation. And so this issue of equity is near and dear to my heart, and I'm very interested to hear what the panelists have to say today regarding the topic of equity, although I'm sure organ transplantation is a bit tangential to the topic. But I do have firsthand knowledge of the challenges of equity from this experience from the ground up. All too often, terms like equity and disparity aren't even mentioned until systems are built. We don't worry about equity until we see inequitable impact, and by then it is often too late. Indeed, the entire point of the ELSI LHS Symposium series is to ensure that these kinds of ideas are built into learning health systems from the ground up. The panel will talk about the patient in the system today, and what they might owe future patients, and what we as policymakers owe to them to ensure that what we build is just and benefits are derived for all. Our first speaker for this panel, Dr. Kenneth Goodman, is founder and director of the University of Miami School of Medicine's Institute for Bioethics and Health Policy, and co-director of the university's ethics programs. He is also a co-founder of the North American Center for the Study of Ethics and Health Information Technology, a partnership with the Center for Bioethics and the Regent Street Institute at Indiana University. In addition, Dr. Goodman is a professor of medicine at the University of Miami Miller School of Medicine, with appointments in the departments of philosophy, public health sciences, and others. Welcome, Dr. Goodman. Our second speaker, Dr. Junho Yu, is an ethicist and translational researcher at the University of Washington. A public health geneticist by training, he is recipient of a Career Development Award from the National Institutes of Health, National Human Genome Research Institute, which is focused on supporting decision-making and return of genome sequencing results in underserved and underrepresented minority populations. Before academia, he worked for over a decade in the nonprofit sector of minority health issues and continues to work with diverse communities and community-based organizations on a broad range of community-driven efforts involving research and evaluation. Our final speaker is Dr. Deborah Matthews, a geneticist and bioethicist by training, who focuses on ethics and policy issues raised by emerging biotechnologies, with a particular focus on genetics, stem cell science, neuroscience, and synthetic biology. She is Assistant Director for Science Programs for the Johns Hopkins Berman Institute of Bioethics and is an Associate Professor in the Department of Pediatrics at the Johns Hopkins School of Medicine. Dr. Matthews has also spent time in the Genetics and Public Policy Center, the U.S. Department of Health and Human Services, and President Obama's Presidential Commission for the Study of Bioethical Issues. Finally, joining us for the discussion portion of the panel is Dr. Patricia Mullen, who is a professor of medical education at the University of Michigan Medical School's Department of Learning Health Sciences, where she focuses on the theory and practice of evaluating medical education programs designed to promote compassionate and competent care. A pervasive theme in this program is the study of educational innovations that have traditionally not been part of medicine's focus, such as palliative care. She is the former president of the American Association for Cancer Education and is the current director for the Medical Education Scholars Program. I'd like to welcome you all. After the presentations, we will come together for discussion and questions, so please hold those till the end. Dr. Goodman, the floor is yours.
I saw you with a clock on your thing. I thought you were the timekeeper. Oh, okay. What are you starting at? 15.
I just want to make sure. Okay. Takes me 15 minutes to clear my throat. Thank you very much for this and for including me. I am excited about this opportunity, about our growing collaboration, about the very cool idea of looking at ELSI issues and learning healthcare systems. At my institution, and I suspect many of yours, your scientific and for that matter your clinical enterprises are driven by a number of different values, a number of different institutional forces. I find that my colleagues are really concerned, both because they're sincerely worried about getting it right, but also because they are regularly reminded by the compliance office, the risk management office, the office of the general counsel, that there are dark and evil forces, and if you have a misstep here, you're going to get in trouble. And that the burden of advancing well, from everything from better science in general to the very idea of a learning healthcare system, that burden is on the university. The university, the UM as we call it where I come from, must have been any ambiguity, is like UM. Somebody here from Manitoba too, right, from UM. We all have very similar missions, and I think we have very similar values. And what I wanted to share with you today was the idea that we need to broaden that just a little bit. At one point, in response to what someone was saying, I wanted to blurt out. How should I put this? Sorry, they're all sorry. Sorry to have all these impediments to having us help prevent you from dying too early. It's okay to be a little bit provocative, right? I've been given just a little license, a brief license. But we want to move forward in a sober way that actually accomplishes what are sometimes contradictory values. I hope I don't say anything that might untoward. And in fact, I think what I have to say is actually obvious. To quote a dear old colleague of mine from Dartmouth, if I seem to say anything profound, you've probably misunderstood me. Clinical and population health science have always been information intensive, able to presume the consent of beneficiaries, and quite utilitarian. We only recently thought, can you imagine Jon Snow? No, I don't mean that one. I mean the one whose cholera patients lived around London and he put dots on a map, right? It would be unthinkable for him to have been told that he has to get someone's permission to put a dot on a map where their house is. I was talking to a colleague. Suppose we were both. You're a lawyer, right? I
am a lawyer, yeah.
Right, I'm a philosopher.
Yeah.
Well, no, I think we have a very cool multi-specialty group. But suppose, for example, we're patients, and our doctor here examines you and treats you for your left kidney disease. Does a good job, thank you very much. And then later discovers that I have left kidney disease and wants to treat me. Would it be okay if she used what she learned taking care of you to treat me?
Yes.
Does she need to ask my permission to do that?
No.
It's a reductio argument. The entire history of the health profession has been based on observations, analyses, and the sharing of them. Now, obviously, it's a little more complicated than that now, but I want you to hang on to that core value. Okay. The scope of what we're trying to capture and make sense of and metabolize is vast. I find that as the information scales up, if not our ability to manage it, we need to be more nimble and smart about thinking about how to organize it so that it's parallel to those other, and I think uncontroversially shared values. Okay. By the way, our colleagues in epidemiology and public health would be forgiven if they blink their eyes at public health departments have never had consent forms, have they? It'd be irresponsible of them to go around and say, may we put the fact that you had the influenza or HIV and add that to our database? So I might say no, in which case your database is useless. We've had discussions so far about different kinds of data and sources. There's clinical data, research data, public health data. There's a growing chorus, if you will. I think it's a fine chorus that says these are artifacts. These distinctions have evolved because that's the way we've our risk management and legal system identifies risk, but I would suggest in this learning healthcare system, it's a distinction without a difference. What does it matter under whether you learned it in a clinic, whether you learned it from a research protocol, whether you learned it because you were gathering public health data? Somebody's already mentioned the right to benefit from science. I'm of the view that privacy and confidentiality were never seriously considered to be hard barriers, that research has long relied on trust, which most of us still enjoy, I think, at our institutions, and that the way to move forward is to have better protocol. I think the greatest threat to our institutions actually is nothing that patients worry about. It's ransomware. And if you're worried about trust, worry about it there. Not because a bunch of people of goodwill were trying to do better science, but that's an aside. I think that some of the reasons we have challenges with the groups that we want to engender trust in, maybe it's a matter of health literacy, but it's also a matter of we're very, very fashionable creatures, and we talk about these data and clouds and big data and super duper big data, and I think all of these terms serve us poorly and undermine what is already a really difficult evidentiary challenge related to getting people to understand what it is we do in academic medical centers and what, in fact, we're aspiring to do with learning healthcare systems. I would urge you also that the uses of the information technology raise challenges, ethical challenges that are not simply related to privacy. They're related to appropriate use and users of information systems and decision support systems. The role of humans in making decisions, I think, is really quite challenging. And I think we've also made so far a complete hash of interoperability. If I were not going to trust you to use my data, it wouldn't be because I think you're going to say Ken's got left toe disease. What was it? Kidney disease. It'd be because I know y'all can't share data with each other in ways that matter to me. I'm a philosopher who chairs ethics committees, and I write notes and patient charts in different. And I thought, wouldn't it be nice if we could have the same structure for do not resuscitate order status in both vendors' charts? Wouldn't it be nice if we sort of knew when we were supposed to not resuscitate a patient? Is there market share that the electronic health record vendors can gather on how well we make sure we don't not resuscitate people inappropriately? So I brought together a meeting. Well, I thought I was bringing together a meeting of different vendors so we could share best practices, and some of them didn't come, you see, because they regarded their screenshots as intellectual property and didn't want to share it. If your patients don't trust you, I don't think it's because of you. I think there's something else they don't trust, and you are and we are the representatives of it. I just saw this and I thought, how. As you can see, it's a storage device for information, 1956. Now, I do not intend to suggest that privacy and confidentiality are not really important, but as you've already heard, they're not absolute values, and we make a mistake if we don't balance them against others. I want to suggest, and this may be the first provocation, is learning healthcare systems raise no new ethical challenges. It's just a lot more data and a lot more benefit to be gained from it. I do not think that the people we call privacy advocates who insist that privacy always wins are right, and I think we have given them far more bandwidth than is credible. I had this awful hypothesis. Wouldn't it be interesting if the people who we are most concerned about, how should I put this? Is this being recorded?
Yes,
Good.
live.
Oh, good. I had the thought that the people who want to opt out of all the systems because they want to invoke their right to privacy, wouldn't it be interesting if that's a certain percentage? And we're trying to study this. In fact, the project someone mentioned with the IU, University of Florida, and actually University of Miami project, is trying to identify what, in terms of electronic consent, who opts out and why. And there's still information to be gathered there. But wouldn't it be interesting if you found out those who consistently opt out of analysis of their de-identified data also believe that vaccines cause autism, also believe that fluoride is actually it might be a Russian plot now, or who believe we live in a country that doesn't have enough bullets and guns. oh, what if those cohorts overlap? By the way, if anybody here believes that vaccines cause autism and believes that we need to have more guns, I'm sorry, I was not speaking to you. But we do have people who, in fact, emphasize privacy over public health, risk little, if anything, and benefit from others' contributions. We're all as healthy as we are because people we trust analyze information of people we don't know to learn how to inform clinicians and people in public health and policymakers how to reduce risk and improve the quality of health care. So if I were to say to you, what do I want my daughter vaccinated for? Thank you all for getting yours vaccinated. Or if I say, if I ever needed a kidney, I'm really glad y'all are organ donors, but I sure wouldn't want to do that, being so yucky. Or I really want to make sure that I have good health care, good law enforcement, good defense, good environmental protections, and good health care. But you wouldn't want me to pay for that, would you? That'd be big government. Couldn't possibly have that as a matter of unpacking my moral responsibility to my compatriots. Let the recording show that I smiled significantly at that point. That I think that what we can do, and this is a thread, by the way, we were not in touch with each other before, so I hope what you're able to do, Jody, is weave these together in ways that I think will be most compelling and useful for a successful evolution of learning healthcare systems, is let's make clear that we do not need to deprive ourselves of privacy rights in order to improve our health, that we need smarter laws and policies, that we need to recognize our duties to each other, that selfishness is still not a virtue, no matter how many times people tell you it is, no matter how many times, is that unconscious? Does anybody disagree with me? Of course not. That learning healthcare systems are the manifestation of that understanding, and that the public health obligation to gather and analyze data in a responsible way is perfectly analogous to that of nurses and physicians to treat their patients. I note that those of us who get to teach nursing and medical students tell them they have a responsibility to take care of people independently of their ability to pay. I assume that's sort of uncontroversial also. Well, what happens if you happen to live in a country, hypothetically, that didn't have a functioning healthcare system? And what little of it worked, there were actually people hard at work to try and undo it. Can you imagine? And that reduces coverage to people who, when they get sick, are going to show up precisely at the institutions where I've told my medical students they have a duty to treat them. Stop turfing your social problems to medical schools and public hospitals. The trust is, as you've already heard, we weren't in touch with each other, so that those of you who are saying, how cool is it that everyone's mentioning trust? Trust is complicated. It's really complicated. As I've already hinted, I think the reasons people don't trust us in academic centers is not because they think we're going to put in the newspaper that they've got left kidney disease. I think it's because they think we're selling their data to somebody. I think their motivations, and there's some research that shows this, when you ask ordinary people, may we use your information? In some jurisdictions, they say, we thought you were already. It'd be irresponsible of you in the public health department not to do that. That's what civil society requires. Thank you for your service. As opposed to, how dare you use my de-identified data that you could have re-identified if the hackers in Estonia had gotten hold of it through the ransomware. But you didn't. So thank you for doing a better job helping take care of me. The ELSI conference is something that when I first heard about it, I was very excited about. There's a national group that through the informatics and ethics and ELSI communities are moving forward in ways that I think are exciting. And I just, to remind us why it is we want to have that and how it is that we can actually make a partnership that puts ethics at the front table. We have precedents for all of this. I'm from, you all don't have many hurricanes here, I've heard, but making big decisions that affect lots of people with probabilistic data may be the greatest challenge we face. The trust that we want to underscore is trust that I think patient duties match, and I've enumerated a number of them here. We need to earn our trust, but we need to not bend over in the directions I think some people suggest that we need to. Here you see Ken's suggestions for how we can do that, which I will leave there as I pause with you about to say 0 minutes remaining.
You have 30
30
seconds.
seconds. Well, I just want to say 14 things. that right, the right to benefit from science, and our duty, our motivation, the spirit of what those of us in academia want to do when it comes to reducing the burden of disease and improving the health of populations, I think is an opportunity. My only despair is that we actually are surrounded by compatriots who don't recognize that one of our greatest public health problems is lead. I mean bullets, and that their values are off a quarter of a turn in ways we've never seen before. This is a bit of a blip in the radar that now is shared by a non-trivial percentage of our compatriots, and I think we have an opportunity to remind them why it is there's some values that are greater. Thank you.
It's all good. Right. So, thank you very much. I'm a lot shorter for the opportunity to speak here today, I guess, and just share, some of my thoughts. We'll get back to that in a second. I just want to lower your expectations a little bit because this is like a totally new topic for me in thinking about learning health systems. It's just not where my head has been, at least explicitly, and so bear with me. I hope what I say is relevant in some ways. And also, I just want to clarify, I'm actually part-time at the University of Washington, or UW, as we refer to it. And in that capacity, I spend the rest of my time working directly with community-based organizations in doing community-based research, as well as research that's focused on ethics and translation. And that is going to probably come through in this discussion. So sometimes when I'm talking about sort of constituents, I'm thinking about not necessarily patients as patients defined, but in the context of sort of just living as people who live in different worlds. So. And for some reason, when I was asked to come here and I started thinking about learning health systems, it just reminded me of Isaac Asimov's Foundation. And here's a little description of it that I kind of thought was interesting. For 12,000 years, the galactic empire has ruled supreme, and now it is dying. But only Harry Seldon, creator of the revolutionary science of psychohistory, can see into the future to a dark age of ignorance, barbarism, and warfare that will last 30,000 years. To preserve knowledge and save mankind, Seldon gathers the best minds in the empire, both scientists and scholars, and brings them to a bleak planet at the edge of the galaxy to serve as a beacon of hope for future generations. And he calls this his sanctuary the Foundation. And so the Foundation could represent sort of a dark Uber LHS, right, learning health system. And like the Foundation, LHSs, might face sort of this constant challenge that despite sort of the immense predictive power, what you could really do with the science, there are these anomalies, these incomplete data sets, these incomplete sets of knowledge, these gaps, and that subvert prediction on this galactic scale, right? And okay, so that's one dark reading of it, but on reflection, I think the comparison also prevents a more fundamental question about, or for learning health systems, that what knowledge should inform healthcare or what health-related decision-making to improve human health, right? So what are we actually talking about? And I'm ignorant enough to ask those types of broad questions here. And so as we think about health equity in particular and what that might demand of learning health system, I ask you to keep that scope of knowledge, that epistemic question sort of at the front of your minds. So this might be too obvious, but I entitled my talk Minding and Mining sort of at the same time, the gap, to reflect both the promise, obviously, of mining the data to learn about and ultimately reduce health disparities, as well as to recognize that throughout the process, there's going to be a number of issues that we need to be mindful of. And in an analysis of this dissolving line between research and healthcare in the context of genomic translation, some of my colleagues and mentors, really, Susan Wolf, Wiley Burke, and Barbara Koenig, situated us in the ethics of sort of T4 phase translational cycle, is what they call it, right? And the sort of cycle that they've come up with. And to quote, they state, the T4 stage, corresponding to the outcomes phase, finally addresses patient and population health impact. The ethics of outcomes assessment becomes relevant. A core issue is whether the intervention alleviates or exacerbates health disparities. And this makes central the ethics of evaluating and addressing health disparities, including justice, stakeholder engagement, the inclusive governance of healthcare research, delivery, and evaluation. And I think that sort of sets the stage a little bit for what we've been talking about and what you also talked about last year. So today I'm just going to go over some points. I think Jody actually did a great job for me, so I won't have to go into detail about the 2016 symposium and what struck out as important to me. Then I'm going to sort of highlight my normative 2 cents, I guess, about group benefits and harms, which is something I don't think anyone else is maybe explicitly thinking about. And then end with what research questions we should be asking in the space of learning health systems to promote health equity. And that's not that I have answers, but that I think it's a question to pose to all of us here. So starting here, Vence, oh, my picture is not there. Maybe it's an earlier set. Okay. So Vence Bonham actually, that'll be interesting. Vence Bonham, sorry, different set of slides, argued really for genomic inclusion, which I think is an interesting point, right? That we need to, in order to address the equity, the differences in benefit that accrue from genomic information, we need to be inclusive. And that's sort of we see as an input point, right? How do we sort of address the input of the data sets that we have in order to encourage equity in the end? But I think it's equally important for us, and in this space appropriate, to think about the outcomes and how do we ensure that follow-up from genomic information, that the appropriate care is being able to be provided in a way that places benefit in front of the patient rather than the potential harms. And so in that sense, I encourage us to think about, in all learning health systems, to think about sort of early adopter settings, usually genomic medicine, usually medical genetics, versus sort of those later adopter settings within a large system where you might have FQHCs or sort of that setting in which there's a lot more underserved populations being served in that setting. And that think about those differences and what the benefits are going to be and whether they can be accrued or not, as sort of a lens to sort of take on this topic. This is actually a slide from Yvonne Lewis and Kent Key. And again, Jody set it up. They talked about this continuum of engagement and research, which is, I think, very appropriate and very sort of grounding for everyone. But I think another key point on community and stakeholder engagement is to determine what constitutes actually, good engagement, things that we value, in different phases of research. So going back to that translational cycle, at those different phases, what are we talking about when we talk about engagement? It's not just at the front to get them in the door, to get them enrolled, to get them in the sample and to be done with that. But it's how in each of those stages are you engaging our participants and as communities of people coming to us. That one's not there. Okay. So this is a slide from Rich Sharp, and I should go to here real quick. So this is a slide from Rich Sharp's talk, which, he really emphasized, again, community engagement, that you can do it, that you can work with advisory committees, but it takes money to do that, and you need the resources for it. That's all good and makes sense to me. But what's also interesting is that he really focused on sort of this, and we heard it earlier today from one of the speakers, the good for society versus protecting individuals from harm. And I think that's very appropriate, but it's also sort of interesting to me that that's always sort of the dichotomy that we place in front of ourselves. And so let's just keep holding that for just a moment too, and I'll share again, thinking about Patricia Kingori's work, that she shared sort of this point that systems and structures have politics and ethics and an imagination about their users with positive and negative effects. I'm trying to string together 2 ideas here, but and I do this too, right? We all do that. We sort of make our assumptions and sort of see and start to construct people and groups and populations the way that we need to see them for our purposes. And so what I'm suggesting here is that we could actually think about this tension a little bit more in a more complicated way, that we start to place sort of both on Rich's scale and on Patricia's insight, that we can consider groups not just as aggregates of individuals or as populations to be studied, but as those with collective interests who have common and often local experiences of social determinants that might impact the outcomes in our healthcare system. So thinking about sort of group benefits and harms and introducing that topic, it derives from my Career Development Award, and we have a work group that's been working on this topic called the Group Benefits and Harms Work Group. And you might be wondering, so what is he really talking about, right? So what are group benefits and harms? What's a group? What are you talking about? So we define groups as sort of being distinct from populations in that a group can be self-identified or ascribed, such as Korean Americans, or they could be organized around a condition, like a disease condition like autism. A group could involve some form of shared social experience. So we're pretty expansive in how we think about groups, such as living in poverty, right? Could be thought of as a group, especially in a local environment, right, a regional environment. Groups can include those that are sort of legally recognized. So we think about sovereign nations and Native American communities here in our country. And then we also sort of recognize that groups are often emergent and dynamic, right? So it's not like we don't want to just stabilize sort of what we think of as a group, whether it's sort of culturally stereotyped in some way, but thinking about them as shifting and changing, that we need to reassess and think about that over time. So in that sort of setting, we can think of classic group harms as being sort of a violation of someone's reputation or identity as a group, such that, a hate crime doesn't just affect the person who experienced the crime, but it affects everyone who identifies with that group. And another type of sort of group benefit that we can think about that we've been kicking around at the University of Washington is APOL1 genetic testing and its association with, the potential to reduce disparities in end-stage and chronic kidney disease, especially among African Americans, because it's a condition that's disproportionately suffered. And so, there are ways to think about this. And so thinking about our preliminary framework here a little bit, again, we distinguish groups from populations, and then in genomics, we've sort of tended to sort of focus on addressing group harms, but we haven't really thought about group benefits. So we really wanted to lay that out on the table as a possibility for us to think about, right? Again, risk versus benefit in our assessments. We also wanted to consider justice not only as distributive, not only about handing out those chits, but also involving recognition of groups and valuing their full participation in society, coming from a tradition of sort of thinking about justice in a more complex way, I think. And then we consider we emphasize the importance of considering how social position frames what is seen as a benefit or harm, right? We all sort of think about what benefits and harms, but we can't see them sort of beyond our own ken in some ways. So we need to be able to sort of think through that. I'll just go through this really quickly. It was from an earlier talk that I gave in the past about all of us and sort of thinking about justice and equity. And I think it's a good case example for us to think about how to apply this thinking. So taking just a moment, given sort of all the potential for all of us to enable precision medicine, and that failing to include underserved populations threatens that greater disparities in healthcare, starting really in genetic medicine, I think we get that point that's articulated by Vince Bonham, right, that we need to be inclusive. But yet we tend to focus a lot of our attention on return of results, and when that's really sort of additional or secondary to the broader transformative potential of the initiative, which is the knowledge gained, right? Yet the potential for receiving results, at least to some portion of participants, is significant, right? Some people might really be helped in this setting, but they're really limited to those who are able to follow up and benefit from that type of care. And as such, we're explicitly concerned that benefits and risks will differ between the average participant who comes in through a health provider organization versus those through historically underrepresented, underserved sort of mechanisms. So, in addition, sort of the potential for group harms and benefits is felt more acutely among some underrepresented groups. And rightly, the PMI actually, from the very get-go, has argued for inclusion and partnership and benefit and preventing group harms. All criticisms withstanding, I think that was very foundational in its formation. And given these dimensions of all of us and an underlying value to minimize harms to social groups, the underserved, and to PMI itself, decisions about return of results, we think, should be evaluated from the perspective of the most vulnerable, and in this case, those historically underserved and underrepresented in genetic and biomedical research. And I'm not arguing that this ought to be the only criteria. That doesn't really make sense. But it's a key criterion that we ought to be thinking about when we evaluate sort of the action steps, the steps that are being taken in the All of Us initiative, and that would impact sort of our return of results policies, our practices, et cetera. And I know that John has already heard this in the past, and we've talked a bit about it. And I see that and feel that coming from all of us very clearly. So what questions should we be asking in the space of learning health systems and health equity? And many of you have probably seen, we've all gone to the trainings. This is sort of thinking about equity. There's the idea of equality that, just giving everyone the same thing just doesn't get us to equal levels of much in terms of outcomes. We think about equity as being sort of this focal point of if we sort of tailor and differentiate what people's needs are, that might get us all to some sort of state. There's the more radical view of let's just tear down the damn wall, right? Let's just get rid of the barriers that result in differences in health outcomes, et cetera. And so then, you start to think about if we're thinking about equity in this way, maybe we have an opportunity in learning health systems to think about what are the outcomes of equity strategies and policies in this context, right? Whether that's organizational policy and governance changes, or whether that's actually the work being done out in the community that's related to or being done in conjunction with learning health systems. Do improvements in social determinants produce healthcare outcomes? I really wonder about that a lot, and I wonder if that's something I bet people are studying. I don't, but I hope that that's a key component of when we think about learning health systems. And do equity strategies and policy interact with improvements in social determinants? That's going to require different sets of data to be combined and worked on together, but I think there's some possibilities there. I just ignore this. That was not supposed to be there anymore. Sorry. Thinking about sort of what the gurus in health disparities research have been telling us, I think that we can sort of make our efforts to train our eyes on interventions that address race and racism and structural inequalities a bit more, at least ask that question in the learning health system context, and what are the opportunities to contribute there. I think looking at informatics strategies and health IT in particular gets really interesting. I really like the concept here on the third sort of row section about community health informatics. So I do a lot of work with community-based organizations doing needs assessments in their local, very small, marginal communities in some ways. And that how can we tie that data back into consumer health data, to population level data with the public health departments, and with the learning health systems, the Department of Pediatrics, the Seattle Children's Hospital that I work for and work in. How does that all fit together, and how can we actually expand our cycle of learning, right? This is about health IT. This was a report put out by NORC 7 years ago, I guess. And again, this was a place that I found some interesting questions that they were asking about sort of what are, some key questions like what health IT tools have potential for greatest impact in communities with health disparities, unintended adverse consequences of health IT, what are the barriers for vulnerable populations, how can systems be designed to address these barriers? Those are the types of questions that they were asking. And what's interesting to me is that those are, I assume, questions that can be asked in a setting in which we're really moving toward more digital and health IT sort of informed healthcare. So I had a few other thoughts, and I guess I'll just leave with them very briefly. This topic for me is a much larger project about individualistic versus collectivistic ethics, and how do we sort of harmonize or deal with those things. And I study them in the context of immigrant and refugee communities. And so I encourage you to sort of, again, look from the 20,000 feet or 30,000 feet perspective and see where are those tensions in our settings of learning health systems. The use of race in research and medical practice, I think of as both a threat and a target. It's a threat when it results in cultural and biologically reductionistic conclusions, but it's also an opportunity because we can sort of actually work with people who identify in these ways, in real world ways that have impacts on their lives. And then I think there's a lot of work being done on identifying new digital divides that are also e-health divides, and that they're evolving norms about what we consider to be sensitive information and what privacy means, that we should really be investigating in that space a bit more. And maybe, again, LHSs provide that as an opportunity. And finally, on trust, because it's that pervasive theme that we've seen. I wrote on my little widget on the table, gear, thank you, sorry, gear, I'll be official. I put trust in the middle, and I put an arrow to challenges and opportunities or threats, or no, challenges and strengths. Because I think on the one hand, yes, trust is key. It opens doors, it gets people in the door for research. It's also, a very important piece to the provider and patient interaction. But it also sometimes, at least my experience has been on all sides of the fence, trust sometimes also alleviates personal responsibility to the extent that they just give me all the trust, right? And I kind of feel like I can do anything I want to do in my research, or I feel like, we've heard this in our bioethics sort of seminars, that we're sort of facing this problem that in a patient-centered sort of shared decision-making context, too much trust can also be an issue, right? Because you're not able to engage in a way that helps to support meaningful value-based decision-making. So just as a little caveat to think about that. And then finally, that there's another way to think about trust as trust in people and institutions, but also as trustworthy practices. And that maybe we can also focus on the actions a little bit more that might help us to identify sort of what's on the line in decision-making. So I'll end there, and thank you.
Thanks. Hello, thank you for having me. We, as noted by the first speaker, we did not share these, so I'm going to be echoing a bit of what you said already, so apologies for any, no, I do not want to get on the online system, any duplication. I was asked to talk about respect for persons who make up the LHS. And I am going to do that I'm also, this isn't what I spend all of my time thinking about. I spend a lot of time thinking about genomics and return of results and all of that. So that will be woven in here, but I'm taking this in a very sort of straightforward way. And I'll be talking about it literally, like the literal use of the word literally. I will be talking about literally respect for persons and equity, and then what it means to take them all together. Oh, I'm forwarding it on my machine and not here. Sorry, you missed that slide. So respect for persons first. Of course, in the Belmont Report, respect for persons, which is usually expressed through informed consent, is based on individual autonomy. I am not going to be talking about informed consent here. That's the focus of the next panel. So I'm going to be focusing more on the second part of what it means to respect autonomy. So to give weight to an autonomous person's considered opinions and choices while refraining from obstructing their actions unless they're clearly detrimental to others. This was brought forward into the document, the Faden et al., so Beecham et al., framework for ethics in LHS as an obligation to respect the rights and dignity of patients. In interpreting the obligation to respect autonomy in learning healthcare contexts, we should assess both whether a learning activity unduly limits the choices of patients and the value of those choices to patients. To take one example that I'm much more familiar with, that of genetic and genomic testing, which has already been talked about by a number of other speakers. I mean, genetics and genomics is really sort of an obligate learning healthcare system case, right? Because I cannot tell you anything about the meaning of your genome unless lots and lots and lots of other people are willing to share their genomes and their healthcare data. It must be the case. Right, so this is it has to be a learning healthcare system in genetics and genomics. And it's where a lot of the conversations that we've had already about return of results has taken place. So given that in order to imbue any meaning in individual genomes, we need lots of data. We need lots of people to trust us with their data, right? But despite the fact, and this has been alluded to as well, we used to think that de-identified genomic data was risk-free as long as we kept it private and confidential. But increasingly, we know that that's not the case due to the fact that we share stuff online and people go to Ancestry.com, and there is more and more and more data about us online all the time. So these data are increasingly identifiable, which means that all of the systems we used to use to eliminate the informational risks of genomic research aren't working anymore, or at least not working as well as we used to think they used to. So because of issues of identifiability, this research now comes with risks. And we have to think about what we can do in our conversations with patients and research subjects that will enable us to, in some way, mitigate those risks and maintain trust. I've argued elsewhere, and I'm sure many people in this room agree, that returning results is one way to do that, reciprocity, right? It is an expression of respect. It supports autonomy by not limiting the information people have upon which to make decisions and upon which to act, that second part of supporting autonomy. It has value to patients. We know most patients want these data. If you ask them if they want it, they will say yes. In particular, if they know that you're going to have it already anyway. If you have their data, they want their data too. So we know it has value to patients. It might offset the risks, the informational risks of participating in genomic research. And we hope it fosters trust. And I think this is particularly, and trust as the theme here, right? This is particularly important in learning health systems where we will be asking for consent less, right? And if we need to ask for consent less through authorization and notification and all of that, other ways of doing the research, there needs to be a high level of trust in the system. And this is a system, both research and medicine, that has frequently failed many of us. Which takes me to equity. So the Merriam-Webster definition of equity is justice according to natural law or right, specifically freedom from bias or favoritism. Faden et al., in their 7 obligations of a learning healthcare system, include an obligation to address unjust inequalities. I think this is fairly revolutionary, and I was thrilled to see it. So it was mentioned in my bio that I work across a number of different areas of emerging biotechnology. I tend to view each new area or new technology as a new opportunity to get it right. It being, innovation and governance of a new area of technology. And when I talk to scientists about this, and I'm a scientist myself, I say this with love, but still, when I talk to scientists about designing into the research and into the technology accessibility on the back end, they say we cannot be responsible for solving our social problems. Right? We can't, that's not on us. This is a bigger issue. We can't be responsible for doing that. I often say yes, but you could not make it worse, which is a lower bar, but would still be awesome if they would do. But so Faden et al. Actually said, we have an obligation to address it. And I mean, the problem has always been that if it's nobody's responsibility, if it's not the scientist's responsibility, if it's not the school's responsibility, if it's not the healthcare system's responsibility, it will never get fixed, right? And if it's anyone's responsibility, it has to be the responsibility of those professionals who are working in the service of improving human well-being. So I think this is the place to do it, but it's a heavy lift, and we have to be quite thoughtful about it. So we know that there are differences in access to care, right? By socioeconomic status, racial groups, ethnic groups, geographic differences. We know that different hospitals have different patient populations, right? I have a couple of different focus group-based projects. I have one in working with folks at Brigham and Women's, where our sample of focus group participants was almost entirely white, and almost every single one of them had college or graduate degrees. That's not the general public, and what works for them is not going to work for everyone, and the care they have access to is not the care everyone has access to, right? Or I trained at Case Western Reserve in Cleveland, where we have the Cleveland Clinic, the Borg, Resistance is Futile, which is similar to Hopkins, a huge hospital system taking over everything. And then there's the community hospital system. And they have very different patient populations. Different sides of town, very different patient populations. So where is the learning health system going to happen, and who's going to benefit from that, right? Thinking about how individual learning health systems and regional health systems are going to work to deal with issues of equity. Where will the learning health system be? How will information be shared across hospitals? Within an individual learning health system, how will information be shared with patients? Right, you brought this up in your talk, in particular about the health IT stuff, right? How will preferences be solicited? And I've done this much research in learning health systems, But I'm very familiar with another system where there's a lot of disparity and communication is hard. So my kids go to Baltimore City Public Schools, and communication and engagement across diverse populations is really hard. And it's especially hard to do it well. And we need to be thinking about these issues, and I know many people are, but we need to be thinking about these issues as we design these systems, because this is an opportunity to get it right. Oh no, I pushed the button. Oh, it went bad. Having two computers up here is confusing to me. Does that get me back? Okay. So then specifically with regard to equity in genetics and genomics, I mean, you've already seen the slides, Vince Bonham slides. There have been other papers as well demonstrating that who we sequence is not uniformly distributed across the population, right? And there are, the nature of genetic data makes it such that who we sequence matters with regard to who then has access to what we learn from that research, right? There are differences in the level of variation and in allele frequencies across populations, and that has implications for the meaning that we draw from those data. So having a failure to have just distribution of those data bakes in problems for downstream access to benefits. And we also know that populations who are underrepresented in genomic data are also more likely to have low levels of trust in science and medicine. Right? I come from Johns Hopkins. I have spent the last 7 years talking about Henrietta Lacks and working with her family in groups in Baltimore and talking to Baltimore City kids about what Hopkins did. And in this case, I would certainly argue that it's actually us that they don't like. And it's totally fair. So then bringing it all together. So respect for persons, just to recap, respect for persons demands both support of autonomy and non-interference in people's ability to act on information. Inequality exists in the healthcare system, totally obvious, and in genetic and genomic research. We have an obligation not to recapitulate or exacerbate existing inequities in our systems. And this is really my point. Baked in is better than post hoc, right? It is, and this is what I say to scientists all the time, it is so much easier to design a system to make just access to benefits easier than it is to design the system, ask who has access, and go, well, it's too late, we can't fix it, right? It becomes a much heavier lift at that point. So how do we do this? I don't actually know. But as a baseline, we of course need a truly functioning learning health system in which knowledge is translated into improved care, both within individual learning health systems and across hospitals. We need to ask the question from the beginning, will everyone benefit equally if it's designed this way? Right, so in the case of return of results, if you're doing that via a patient portal, right, okay, who has access to the patient portal? Not everyone has one of these in their pocket. Not everyone has internet at home. If someone needs, in order to get access to their information, they have to wait until a time that they can go to a public library and access the computer for a 15-minute slot, that's a very different level of access to benefit than people who can download it in an app on their phone. Engage with patients to identify mechanisms to ensure equitable distribution and utility of benefits, and then do the research. Who's accessing the patient portal? Like who is actually logging in? You can find out that information. Who's asking for their data? Who isn't, and why not, or why? And then the next step, and I think this was alluded to on the first panel, are people able to then use those data equally? right? I now have access to the data. Can I actually do anything with it? Do I have access to a genetic counselor? Do I have access to the care that these data would suggest I need? Thank you very much.
Thank you. So we've had the luxury of a panel that's not afraid to take audacious stands, which is always fun to see. So since this whole session is focusing on equity, that's our goal, then what I had the chance to do, because Jody and Kate were so generous about sharing the planning committee's thoughts and the committee's slides ahead of time. There wasn't active collaboration on who said what then, but there was the opportunity for collusion in looking at what themes might be warranted to consider. And what struck me was that this is the group. This is the group that's in the position to really think prospectively and intentionally about what are the practices that we're thinking about with LHS that could actively promote warranted trust. So if we're going to be intentional about this, what are the practices that we're seeing that we could communicate, celebrate, that actively promote warranted trust? And Ken started us out, as did Ann, with thinking about things like we already are seeing really differences in policies towards organ donation, from opt-in to opt-out sessions, then that still have enormous threat to equality in terms of who's actually going to have access to the organs. And, you know, are you in an urban or a rural setting? Then how much you're going to be able to pay? What's the social support that you have afterwards? That person who's going to drive you home from the hospital, as we heard about in the session earlier this morning. So as we're thinking about these systems where what we elicit for information in the LHS, what we make sense of in terms of our analysis, and then how we share information, what strikes you as policies to promote that we're seeing now that actually promote trust in our system?
Hear that, will you? Well, if I might, one of the things that occurred to me about trust, those of us who, for example, have advocated for lots of different technological advances, ranging from stem cells to more budgets for studying interesting molecules to translational science, have had this gnawing anxiety or worry that all the people who we want to participate either in the randomized double-blind placebo-controlled trials to the simple information gathering that we need across the board would be forgiven if they said, I'm going to participate here, whether it's risk or not to me, but it matters more if it's a risk, to generate new treatments and drugs that I can't afford. Yeah. Well, you all talk about trust, and you talk about partnership, and you talk about raising the bar for public health, and you talk about the health of populations. But what I see, and have seen for my entire life, I don't see it getting better, is we don't actually share very well. You talk about equity, we don't have equity now, depending on the population that you're in. So why on earth would I want to put my thumb on a scale that produces more good stuff for those who've got and nothing for those who don't? When in fact we know your databases need to have both if they're to be of any use. Let's reduce that disparity, that inequity, that a bit of failure of civilization, and then I'll give you all the data you want.
All right, we're going to go ahead and open up the floor to questions. If anybody would like to address the panel.
Oh, come on.
They just agree with everything we said.
Okay, here we go.
We need plans.
Must be something you
Just
said.
let me get the mic across the floor.
That's what you said, Dr. Goodman.
So, Ken, this is not well formed, but. Oh, sorry, go ahead. I can form a better one. So Ken, this question's for you, and it's the notion you put out there that people who opt out of data sharing or might be sort of willing to rely, like sort of stand on the backs of the people who are willing to share. I'm curious what your empirical data will say. I would suspect there are a subset of people, and I might even put myself in that bucket, who get all the vaccines prescribed, who've been an organ donor since day one, who is data driven when it comes to gun violence. But those are quantifiable risks. Everyone knows the risks of getting a vaccine, quite low. Everyone knows the benefits, both to individuals and society. That balance seems to weigh in our favor. I think what makes data sharing categorically different is that the risks are not known, not quantifiable in any kind of way. So, we're talking about in the context of good actors trying to do good, trying to make our health better. And I wish those were the only players in the world. I think when we talk about data being sent out into the ether, hopefully to good actors, there's no guarantee that bad actors can't have access to it. There's no guarantee that they can't use access to our data for nefarious purposes. And so I think building those considerations in is warranted in a way that I think the analogy to vaccines doesn't necessarily bear out. There's some out there.
So that's a fair point, Elizabeth. One of the things that I've noticed, part of it is you were arguing from what we don't know. I like to make distinctions among risks, harms, and wrongs. I think it's possible that I can be harmed in different ways, although it's like I'm looking for a good example of somebody whose health data has led to them being harmed, other than the fact that they had a pre-existing condition, right? It might be that I've been wronged in different ways, but it's possible to wrong someone without them even knowing it. What I'm struck by is how, in my own behavior, I will go online and I'll buy something, or I'll transfer money from my bank account to pay for something. And there I am watching in the lower left-hand corner of my browser the magic of the click stream, and how Google and Amazon and Citibank and American Express and Bank of America, whatever the bank is, and they are all scarfing this data up by the shovelful, involving my income, that of my family, that of my Social Security, that of stuff. And I look at it and I say, well, but at least I got to buy that widget quickly at a low price. You say the same thing in my health data. I say, well, wait a second, that's my health data. I wouldn't possibly want to run that risk. I take your point that there's something interesting about health data, but I would have thought the same thing was true of financial data. And I've noticed that we've taken completely different stances. Financial data, whatever, the convenience is worth it to me. Health data, it might help you. I'm not so sure anymore. The risks are too unknown for me to take. And I'm not disagreeing with you. I'm saying I have the same intuition, but I don't like my own intuition. What's the difference?
Well, we should be more protective of those other kinds of data.
Indeed, we should, but I guess what I'm trying to say is, since we're not, we throw caution to the wind when there's no benefit to the community. When there is benefit when it comes to health, that's when we become suddenly really quite cautious. And it's sociological observation, not an ethical one. But I don't see the difference actually, other than that one's commerce and the other's being commodified. I haven't gotten there quite yet.
Well, I think one of them has governance structures associated with it that we can identify, and the other one doesn't. Right? So we're having the conversation around health data, whereas we're simply not having that other conversation. And to your point, Lizzie, and your point earlier, Ken, about the co-occurring characteristics of individuals who don't want to share their data. I mean, something that really struck me, actually, John, that you said in the commission meeting this many years ago, was that in this space, in genomics specifically, right, we, as you said, don't know exactly what the risks are going to be. And what you said was that we need lots of people willing to take arrows in the back, right, and be open to that risk now, not knowing exactly what it is, in order for us to move forward and get past this space and into the nirvana where it all works well. But in a learning health system, I mean, I'm not willing to ask the people who have been systematically disenfranchised to be the ones to take those arrows, right? And that's what I worry that we're not sufficiently attending to that in the move to learning health systems.
Oh, I think we agree. I mean, I didn't make the point clear. Until there's no reason to trust any of our efforts.
Yeah.
Without that population saying that's the old switcheroo over again. Unless you can't provide basic public health, the drugs are too expensive, the doctors are inaccessible, the emergency rooms are closed, and now you want me to contribute to your learning healthcare system?
Yeah.
I mean, I guess what I'm saying is the disparities we already face. It's the moral obligation to share data, sort of with forgive the phrase, it's sort of cateris paribus clause. All other things being equal, I'm a free rider on all the ways, including healthcare, but I'm sort of stupid if I also don't take into account what you've just said. Why would I? There's altruism without any reciprocity ever is what? Not well advised. So we need the best. I think the best minds in Washington are working on this right now.
That was a mean thing to say.
What's that?
That was a mean thing to say.
No, present company excluded.
My question is about reciprocity and return of results to the community. I work with a lot of local health departments. So I got very excited when you said Jon Snow couldn't do today what he did back in whatever. So I went and I said, oh, I wonder if there's a heat map of Jon Snow's findings. And of course there is. It's depicted in a zillion different ways. And so I'm like, okay, public health could have collected that data. If Jon Snow is a public health epidemiologist, he could. But I don't think that a local health department could have reported out that data to the community because heaven forbid it's too granular. And so when I'm having a challenge in helping local health departments find a legal way and an ethical way to be able to return results to communities that are in small enough geographic areas and specific populations so that they can actually have meaningful data and neighborhood organizations and others can do something with it. Any ideas?
So, yeah, I'm sort of familiar, I think, with that challenge, and as well as sort of the larger challenge that public health departments, especially at the county and state level, are dealing with, so sort of this harmonization and merging of all these sources of data that they're somehow responsible for, and they're like, oh my God, this isn't going so well, and there are lots of gaps, and yet the gaps also reflect sort of where there are problems that we want to address with these underserved or vulnerable or at-risk or whatever you want to call them, sort of communities and groups. In that particular case, I kind of wonder if you can start, I'm thinking about Mike Burgess, actually, a conversation we had last night, that maybe it's time to talk with the local community about that return potential and sort of where are the benefits and risks and where do they lie. And maybe not everyone agrees, certainly, and I wouldn't expect them to, but is there a way that they themselves can work with that local county department to come up with a rational system to return? Or, there's like in the PMI, there's the time frame sort of lag idea, right, that I read about, sort of how can you think about that over time? Are there aggregate ways of returning information that's relevant for the neighborhood, the community, right, that in itself will be meaningful to advocate for changes that are maybe more on a macroscopic sort of policy level change, or even a practice change in their local community, whether it's a utility or whatever that is the actor that you need to engage with. But there are ways to think about it, but it's going to take time and money and investment in community engagement, which is always the issue.
If I could add, we have the sad occasion to celebrate someone who did that in Michigan. So it was a brave pediatrician who on her own time said, what's going on with the blood levels in the kids I'm taking care of, and just tirelessly did the t-test that she learned while she was in medical school, tested it out with friends in other health departments throughout the state and nationally, and decided that she needed to voice this. And she was ridiculed initially, really persevered. But what she was able to do in Flint, taking care of that group of kids, then was astonishing. And she was able to draw on tools because there was pooled data then, so that you could look at trends over time and trends over different areas. And it was essentially this one brave woman, pediatrician from yet another Michigan medical school, not ours, that was able to make this case, but also to stand as, I think, an example to celebrate of the, if that really is your focus, if that really is your focus, is the health of this community, and I'm going to look at the existing data and give it medical coherence in terms of the, not just trivial differences in lead, but these are clinically significant. That if we empower people to be champions, we've already seen examples where people are willing to do that. So maybe some celebrating of these kinds of stories.
Well, and to go back to your phrase, which I really liked, warranted trust. It's not just trust, but actual trust that we've earned, right? You're going to have to talk to people. There is no other way to do it but to ask people how they can actually benefit from the work that's being done. Both at the front end, a lot of what we've talked, there's been a lot of discussion of, asking what are the questions that you have that we can help address with the tools that we have, but also then at the back end, although preferably you do this up front too, how can we ensure that you actually benefit from the work once it's done?
And that you understand that you're benefiting.
Yes, that you understand that you're
And so reminding people of that track record. From lead to, does anybody remember the first research on seat belts and accidents in motor vehicles involving kids bouncing around? Really awful data about human injury that was collected from all sorts of reports. I mean, the entire history of what we've come to rely on from our county, state, and federal health departments is a history of people of goodwill saving lives and reducing suffering, and everybody was fine with it. And look at the lives, in fact, that we've saved. It's more probabilistic now, the benefits aren't clear, but we've also had some erosion. I mean, now in my state, if a pediatrician wants to ask a family about whether there's a firearm in the house out of concern for gun safety, that's actually against the law in Florida. Because that would be big government infringing on people's rights to have guns. So you pays your money, you takes your chance as we shift back and forth. Now it's in the courts, of course, but imagine punishing a pediatrician who says, do you have an unlocked firearm in the house? What's that about? Why are we having to defend public health in the face of that?
Other questions?
Actually, can I make a quick comment?
Oh, sure.
Sorry. I think there's a couple other sort of practices that I draw upon from public health that might be valuable. One is, we talk a lot about sort of these challenging topics like trust, uncertainty, probabilistic notions, et cetera. And in public health, there's been a lot of efforts to be able to change the social norms by which we sort of see health in the world, right? And that some people think very, disparagingly, I think of that as sort of another type of social marketing, right? Social construction of sort of our realities. But I think that there's something to be said for how do you employ sort of those norm-changing sort of approaches. Again, with transparency is what's required, right? To be able to sort of shift the balance of how we think about things like security, how we think about, just recognizing that like your bank accounts are probably insured, right, for the FDIC. That just engenders not only as a policy and as a practice, but also as a sense of, oh, I know there's something kind of holding me up underneath there. So if I get totally taken over, there's some actions that I can take in terms of my identity and my financial records. Similarly, in biosecurity and sort of this world of security that we all live in now as compared to 20 years ago, right? There's been a lot of effort to change the way that we sort of see the world, for better or for worse. But I think that, there's potential for that, but it is this sort of question about social engineering that we have to be mindful of. But again, learning health systems and the providers and the systems there are in such a position of power to be able to affect how we see health, right? Remember, like Robert Wood Johnson Foundation, culture of health, sort of this idea of where we sort of move our society, how equity itself, health equity tries to place health and as the principal sort of goal, and that changes the ways in which we choose to govern ourselves, right? So think about sort of those scales of change that we could be engaging in with evidence, right, that we look into our own health systems.
I want to suggest there might be other ways of approaching equity in learning health systems.
Oh, so that's better.
Although the radio has been low. I want to suggest there might be ways of using public engagement to improve the way we do represent equity in learning health systems by letting the learning health systems as they evolve with upfront public engagement shape our understandings of what the health and well-being issues we're trying to address, because communities tell us what they care about.
Right.
And based on the fact that they value what they know now know that people study, they will then take risks and trade off privacy, because they've helped shape the benefits that they see. So rather than thinking about learning health systems as trying to negotiate the challenge of privacy and individual consent against communities, think about communities as helping construct the benefits so that they together agree that the risks or the changes in privacy protection and consent are justified by the benefits that they want to achieve.
Yeah.
Yep. You're here.
Well, thank you for your really excellent points. I really appreciated Dr. Goodman's really very strong thinking about the obligation to participate, and you benefited from what everyone else went through. Others have a sort of right to benefit what he went through. I guess I see another equity perspective is balancing sort of relative power between different kinds of stakeholders, with patients and we the public being one, or public health and patients being sort of two different related groups, and then lots of other stakeholders. Stepping outside of healthcare for a second, so something that sort of made me think about this balancing a lot recently is Equifax, which is, I guess, 4 or 5 months ago or whatever it was, they had a breach. They told us about it 2 months ago, because they needed to sell their stock and do all kinds of sketchy things. I mean, that was almost half, I think 140 million, almost half the country had some of their privacy breached, and some really important things, like identity theft. And I as a customer, or whatever I am upset and don't want to do business with that company, as a lot of people feel. And that's when it kind of hits on us that we don't have a choice, because we're not the customer. 140 million of us were affected, but we're not the customer. We didn't play any real role in deciding about sharing our data or not with them. And we're sort of the raw material and not the customer. And I guess the analogy is, to me, that's the extreme we never want the learning health system to go to. Maybe the other extreme where the privacy people can keep everything in and out of it. How do we think about that balance? How do we make sure we don't go to that far? If that sort of guidepost makes sense. And we have to trust too.
It's not like it's not like our economy evolved based on principles of equity either, right? I mean, all my investments are tied up in soda bottles, and the disparities there. I mean, I think that the credit situation is rigged with disparities depending on where you are in the community. There's no legislation. We have basically created a moral resort area around health information, having watched what's the emotion? As we watch people who have income disparity that you can't imagine, who have a disparity when it comes to workplace, who have disparity when it comes to discrimination. There's education. Thank you very much. Maybe the most important one. And what we've done is we've said, well, what have we done? We've privatized our schools in response to that. Thank you very much. So now we're saying, well, we really want to build learning healthcare systems, and we want the people who have done that to support us when they never saw the benefit they got from the community in the first place. I'm actually worried about asking, just to push the point a little. I'm not sure I want communities to tell me what they think they want. Because depending on the granularity of the community, you might get people doing things like, I don't know, voting. Do you really want to subject public health to that kind of I think we need to listen to them more, but I think part of what's happened is, it's not, one, we haven't listened, and two, we haven't worked together well enough. There's no relationship between our academic medical centers and the communities. It's not that they need to be guiding us. We haven't been listening at all. And that two-way street, the idea that I think most communities actually have a great deal of respect for academic medical centers and for teaching centers and what they will get from in the future learning healthcare system. But I don't think we need to make that a partnership and a constant exchange, as opposed to how can we help you? Because if you ask that and you think that it imposes a duty on you, you might find yourself with some very kooky duties. But that's what we've discovered with Equifax. You bought the ticket, this is the ride, and it's not covered by your $100,000, right? There's investments all over the place that are not insured at all. And if those are hacked, then I'm really harmed. And it was, oh well. It's called When Wall Street Collapses. I'd like to be protected from that. Thank you very much.
I think someone said earlier that there are some things that are very low risk and make all the sense in the world to do, and we should just go ahead and do them, and they don't require community engagement. It's the stuff that bumps up above low-hanging fruit or minimal risk that we have to talk to people. I mean, we just do, and I mean, I really do believe it goes back to an obligation, basically, not to make things worse and to make things better if we can. And I mean, I would love to do it in education personally. If I got to choose a sphere of endeavor, I would do it in the education system, not in the healthcare system personally. But this is an opportunity to do that, and I think we have an obligation to do that. And yes, maybe if they say, if we go to a community and say, what is it that you need? And they say 6 more corner stores, or, I don't know, something that would be like more parking lots, fewer parks. Yeah, okay, we're not necessarily going to work with them on that. But we have to have the conversation and figure out what it's actually important to them that we work on.
I think that's right. And also our history, they will be forgiven for saying, oh, now you're interested in community-based participatory research. You must have gotten a grant for it. Right, I mean, in other words, our partnerships with our communities are need to be improved. They all need to be improved. I mean, the communities we're talking about, they're not stupid. They know that we come around when there's going to be a peer-reviewed paper here, there's going to be a grant there, there's going to be some way or other that my institution will, as opposed to really sincere connections with the lives of ordinary people. We now need to demonstrate those academic bona fides. And we can start, I think, with education. We can start with helping people financially. A little bit of financial literacy, I think, will go a long way. But I think that it's a long road, and our track record is not good. And getting that right, I think, is necessary for the success of learning healthcare systems.
And actually, I'd like to take back something I said. So when the community group says more parking lots, fewer parks, we need to find out why. Right? And what is behind that? Maybe it's because parks lead to violence, and there's something else that we're not getting at, but we have to listen and ask questions to actually get to the answers.
Another sort of facet that just this discussion is reminding me of is the workforce development question, right? And I say that because what I've noticed over the past 20 years, in at least the public health circles that I work in with health departments, et cetera, is that many of the people that I worked with early on who are doing community work, who were really sort of coming at it from that perspective, and they have developed, they've partnered over time and worked within the public health system and are now people working in public health, like, in the county health department. There are people working in the state health department. And the point being is that there's been this shift in the workforce in very positive ways, in my opinion, that, again, blurs or dissolves this barrier between who's playing what roles and what those divides are. And I guess I vaguely remember in reading some of the background on learning health systems that that's another area that we ought to be thinking about as a place that we could, we see that also in the academic research setting, right? Like, that's why the NHGRI gave me a waiver to work at 50% on a grant that I'm supposed to be at 75%, right? Because I was able to argue the vision of working within communities to do this research. But it required a policy change that involved 20 people, or at least an exception made for me. So again, how do you govern to create equity in the work that we do, right? Think it through sort of the whys of the logic and how it all works to your end goals.
So we have time for maybe one, maybe 2 more questions. Karen, did you?
Yes, this question just builds off of something that Josh was saying, which is that in the case of Equifax, we're not the primary customer. Really, we're
The product.
in some ways. So the question I had was, when I think about research, I think of who's the customer for research, who's the short-term beneficiary, and in some ways, I would argue it's the researcher, because it's the new knowledge that's generated that's eventually going to help people and patients. With quality improvement, the immediate benefit maybe goes more directly to patients, because the thing you're implementing, you're thinking is kind of an obvious, this should help type of a thing. Who's the beneficiary in your kind of views as a panel for a learning health system?
I see we're out of time. Humanity. Right? Wouldn't it be? And by the way, we're in North America now, and one of there are actually several countries in North America. The others that are civilized have fewer problems. Wouldn't it? I mean, but we look at travel, we look at the flow of data across populations. I would like to learn from healthcare systems in France and Ecuador and Thailand as well. I mean, I think the goal here, and especially if we're looking for real in a world in a world of genes, wouldn't it be interesting if and ubiquitous travel? I mean, in my community, we've been dealing with Zika a lot lately. So frankly, what local is sometimes hemispheric. And we see this every once in a while when some bug gets out of a box somewhere, and everybody in the world starts thinking, I wonder what y'all do for Ebola here, right? How much money did your hospitals find when there was no money to buy a bunch of personal protective gear for people? There was no money for a bunch of other stuff, but we found that pretty quick, didn't we? Wouldn't it be nice to know about emerging diseases in Africa? Wouldn't it be interesting to find out in terms of environment and climate change how those emerging diseases are emerging, and how even though it's going to be somewhat cooler here than in Florida, I'm here and you have no idea what awful diseases I brought with me. So I want the answer to that to be big and bold and wholesome, namely civilization. And so somebody will say, wasn't that naive? So I can say, absolutely.
I would love for us to design a learning health system in a way that different aspects of it lead to immediate benefits for many different people, right? So quality improvement, yeah, that should, if your system is functioning, lead very rapidly to improved systems and improved care for everyone in that system. But if we're actually engaging with the publics around our institutions, that in itself is a benefit.
Absolutely.
Right? At Hopkins, the hundreds of people, all the faculty at Hopkins, how many of them actually live in the city of Baltimore? Not many, right? So we have segregated ourselves in ways that make engagement much less likely to happen. And so if the learning health system leads to more engagement between the hospital system and the people that we live next to, that is a benefit right off the bat.
It's promoting more into
That will pay dividends down the line as well.
Jeez. Any last comments? All right, please join me in thanking this tremendous panel of experts.